Okay, let's go ahead and get started. I think everybody is looking forward to this grand rounds because in case you've been holed up somewhere and not looked at the news at all, we are in the middle of basically hepatitis A epidemic, which has been going on for some time. For people like me who are true salad lovers, it's been very hard to go places and avoid the salad bar. However, between the choice of eating in an unhealthy manner and getting hepatitis A, I'll do with French fries. So this talk is going to be given by a member of the Infectious Disease Division. Dr. Ramirez is out of town, and so to introduce our speaker, we have Dr. Forrest Arnold, who, as we know, never misses a grand rounds.
I am pleased to introduce Dr. Anupama Raghuram. She's been in our division of infectious diseases since 2012. She graduated from the Federal University of Pernambuco in Brazil and did her internal medicine residency at Long Island Jewish Medical Center and then her infectious diseases fellowship at Rochester Medical Center before coming to us. Here, she is assistant professor of medicine. She's the associate fellowship director. We have a lot of great things to tell you about our fellowship in a different venue, but let me tell you, since I'm talking instead of her, that many of them are because of her and her presence in the fellowship. She's also inherited the medical directorship of the 550 Clinic, which is primarily our HIV population, which continues to increase over the years. And she has been passed that torch, and I will say that it's burning brighter than ever. She has additional certification from the American Society of Tropical Medicine and Hygiene, as well as the American Academy of HIV Medicine. And she is a part of numerous grants, the largest being the Ryan White grant that helps fund our 550 clinic. We take parts C and D of that, and together they combine to be more than $1 million. She's now more active in research and publication, so please help me welcome Anupama Raghuram. Anu.
Hello, everyone. Good morning. I hope this will be a topic of interest. Can everyone hear me back there? Yeah. Okay, so today's talk is going to focus on hepatitis A. This is an update and a review of the data on the current multi-state outbreak. So we will be reviewing the epidemiology and pathogenesis of hepatitis A infections. We will be discussing the clinical manifestations and management of these infections, also looking at strategies for prevention of transmission in a variety of clinical settings. And we're going to review the data on the ongoing multi-state outbreak in the US. So let's jump right into it and go to a case. So we have Mrs. X here. She's 34. She's 24 weeks pregnant, and she's hospitalized with hepatitis A infection. She's worried about transmission to her baby. So how would you counsel this patient? You just observe and wait for delivery because and you know that there may be rare chronic sequelae for the baby from vertical transmission. Do you think she has a high risk of transmission because she's in the second trimester and you should give her immune globulin? Do you think she has a low risk of transmission because she's past that first trimester? Or do you think this infection is unlikely to be transmitted vertically? I didn't have clickers today, so think about it and see if you can come up with an answer. Give you a couple seconds to let that sink in. I think we are more attuned to hepatitis B infection in pregnancy, and we worry about that and we screen for that. But I don't think we traditionally think of hepatitis A in pregnancy. We all know the transmission is fecal oral, so I thought I'd bring this point up. So for this case, actually, hepatitis A infection is unlikely to be transmitted vertically. So now I'm going to walk you through the epidemiology of these infections. So just to go through the memory lane. So since 1947, it was known that there was hepatitis. And they kind of distinguish between two types of hepatitis, the infectious kind, which was the campaign jaundice or epidemic jaundice, and the serum kind. So in 1947, they decided, okay, hepatitis A is going to be the infectious kind, and hepatitis B is going to be the serum kind. However, it was only in 1967 that hepatitis B was actually identified as the agent for that infection, and a vaccine became available in 69. Hepatitis A virus's structure was actually only discovered in 73, and the vaccine was only really FDA approved in the US in 95. So by 96, you had vaccine for high-risk patients recommended, 99 for children in endemic areas, and in 2006 is when this officially became incorporated in the routine childhood immunization schedule. So humans are the only known reservoir. It's a self-limited illness, and there's really no chronic form. And going back to the question we started with, there is really no maternal-fetal transmission reported. There's several case series out in Taiwan, China, where they looked at moms at various stages of pregnancy that got acute hepatitis A, but they did not transmit to babies. That being said, there's a couple of case reports out there about babies becoming infected in the early neonatal period, but it wasn't really clear that there was absolutely a vertical transmission because it could have been in the postpartum period. So that's why the answer to that question was it's unlikely to be transmitted. That's why we don't worry about it and we don't screen for it during pregnancy. Again, this is outside the context of our multi-state outbreak. So we have about 1.4 million cases per year worldwide. In the US in 2016, CDC reported about 2,007 cases. And that year it was 9 cases in Kentucky, which evidently has changed. Once the vaccine was introduced, the rate of infection decreased by 95%. So that's very significant. And this is what I call my gloom and doom slide. So this is all the hospitalizations, deaths, case fatalities, and mortality. I want you to pay particular attention to the age. So as you get older, your rate of hospitalizations and your rate of death increases dramatically. And I want you to pay attention to those age groups because that is going to come into play when we talk about post-exposure prophylaxis. So you can see here that when you're over 70, the rate of hospitalization goes up to anywhere from 42 to 65%. Deaths, if you're less than 40, 0.5% risk of death. That jumps up if your age is older, and in particular in the older age group. And here you can see that with case fatalities. So about 7% if you're in this age group, jumps up to almost 13% if you're older than 70. So this is the worldwide map of prevalence. The darker the green, the higher the prevalence. Anything that's gray is considered very low prevalence, which again, that has changed in the context of our outbreak. But you can see areas of Latin America, like an intermediate prevalence, and whereas in Africa, in Southeast Asia, India, you see a high prevalence. This is very important to know, especially for our travelers going to endemic areas, as you will see later. So let's talk a little bit about transmission and pathogenesis. So we're all familiar that it's fecal oral transmission. There has been person-to-person transmission documented, again, from contact, sharing cups, utensils in a family, that's very common. Also, MSM transmission has been documented. And contaminated food or water source, again, is a mode of transmission. Now, when we go through the pathogenesis of hepatitis A, first you have to ingest the virus, right? Then you're going to have replication in the oropharynx and GI tract. Then the virus is transported to the liver where it further replicates. Then it's shed in the bile and transported to the intestines. And then you shed it in the feces. In the feces, actually, very high levels of virus are shed in the stool, much more so than the amount of viremia that you will detect. Then you have viremia, immune response, symptoms, and resolutions. When we look at this at a cellular level, if you imagine the hepatocyte here, you're going to have viral replication of your hepatitis A. Then your natural killer cells and your CD8 cells are alerted. They come over there. They're going to destroy your virus. But in the process, There's also going to be destruction of the infected hepatocyte and hepatocellular damage. Interferon gamma has a role in clearing these infected hepatocytes. So the more robust your immune response, the more damage you're going to have, the more hepatocellular damage, and the more symptoms you're going to have. Okay, so let's go on to clinical manifestations. And so Mrs. X is asking now how long she was contagious prior to having symptoms of hepatitis A. So your best answer is going to be 3 to 7 days, 7 to 10, 15 to 50 days, or 30 to 60 days. So essentially, this is a question about incubation period, right? So anyone want to venture a guess? Anyone vote for A, just quick hands. Nobody. I see shaking heads. What about B? Anybody? Some folks are saying B. What about C? A few folks saying C. Okay, and D? Anybody? No, nobody for this. So for this one, the actual incubation period is reported as 15 to 50 days. So there was a split there between B and C. So let's look into that a little bit more. So when you look at the incubation period, the average is 28 days, but the range is from 15 to 50 days. So the shortest incubation period is felt to be about 2 weeks. And 70% of adults are going to be symptomatic. When you look at kids, it's the other way around. And again, this is related to your immune response. Remember I said the more robust the immune response, the more symptomatic you will be. So with kids, it's the other way around, especially very young kids in hyperendemic areas. They get it when they're really young. They don't have any symptoms, have long life immunity. With adults, it's the other way around. 70% will be symptomatic. So as far as all through your incubation period, through about 1 week after the jaundice appears, you are considered contagious. Mrs. X wanted to know before she had symptoms, how long is the incubation period, and that's why that was the answer there, okay? And then as far as clinical manifestations, we're mostly familiar with them, but you will have an abrupt onset of nausea and vomiting and anorexia and fever and malaise and abdominal pain. And in a few days to 1 week, what you will develop is the classic, dark urine and pale stools. You have jaundice and pruritus. About 40 to 70% of folks will have those too, and about 80% of folks will have hepatomegaly. As far as complications, the most feared complication is really fulminant hepatic failure. We know there's no chronic form, but there's a possibility of fulminant hepatic failure. And that is severe liver injury, acute liver injury with encephalopathy and impaired synthetic function, so your INR is going to be prolonged. This happens in less than 1% of patients. It's actually closer to like 0.3%. And as far as risk factors that have been looked at in the literature, age above 50 and Hep B and Hep C co-infections may be risk factors for this fulminant hepatic failure. There are some other complications that we think of less, but there is a picture of cholestatic hepatitis, which is basically prolonged jaundice and even pruritus for more than 3 months. This happens in less than 5% of patients. This will resolve spontaneously, and there's usually no sequela. It's just a more prolonged course of disease. What I found interesting is that I wasn't as aware of before doing this talk is this picture of relapsing hepatitis. So there is a possibility that you will have a biphasic peak of disease where you have the acute disease, you get better, all your markers get better, but then about anywhere within 6 months, but most commonly within 4 to 7 weeks, you almost have a relapse. And you have, again, biochemical markers go up and symptoms come back. It's unclear why folks have this. They think it's just an immune response to continuing antigenic stimuli. And the clinical symptoms tend to last 3 weeks in the relapse phase, and the lab abnormalities can be up to 12 months. It's important to be aware of this because now, especially that we're going to be seeing more hepatitis A, to be aware of this picture of biphasic, because it can happen in up to 10% of patients. And you might freak out a little if you see that and they're all better and all of a sudden they're worse again. So be aware of this, that this is a possibility. The other complication that's been reported is that hepatitis A, like many viruses, can be thought of as a trigger for autoimmune hepatitis. So these are patients that have autoimmune hepatitis. They went back and looked, and they had a preceding hepatitis A infection. Again, an association. And this big slide is just for you to have an idea that besides the hepatic manifestations, you can have extrahepatic manifestations, and they're varied, multiple case reports here and there. We don't typically think of this when we're dealing with hepatitis A, but even reports of transverse myelitis, the more common reports were aplastic anemia or thrombocytopenia, and the vasculitis picture, which we also see with hepatitis B, C. I do want to remind you, though, we lump them all together. Hepatitis A, B, and C are very different beasts, so don't think of them as super similar, because the clinical course, treatment, management is all very different. All right, so let's move on to diagnosis. So the diagnosis is basically going to be clinical symptoms and serology. This is just for you to have an idea that even before you have symptoms, you start to see your IgM come up here, right? So by the time you're symptomatic, your IgM should be positive, and that's how you make the diagnosis of acute hepatitis A, in addition to the clinical picture. You can see IgG starts ramping up here, but truly it comes up by week 12 or so, so 3 to 6 months, which is right when IgM is tapering off, okay? And you can also see the duration of viremia, about 5 weeks, and stool shedding, about that as well. So this is just a quick table about the pattern of lab abnormalities. So typically you'll have a AST, ALT in the thousands range or more. They peak about a month after exposure and start decreasing by 75% per week. The total billing is, of course, increased, but tends to be 10 or less. In the cases where you have the relapsing picture, that might be higher. And this tends to decrease within 2 weeks of peak levels. And your alk phos is going to be elevated. About 85% of patients are going to recover within 2 to 3 months. Nearly 100% of folks are going to be recovered by the 6-month mark. So basically, this is what I already said. So clinical picture and serologies, your IgM should be present even before onset of symptoms and stays positive for 3 to 6 months. And the IgG is present in the convalescent phase, and it does impart lifelong immunity. Of course, as part of the diagnosis, you got to work up other causes for obstruction and such, so that's in there for that. So what about prevention? When we talk about prevention, there are 3 situations you're going to be looking at. So hygienic measures, of course, so we know about hand washing, heating food, so to more than 185 degrees Fahrenheit for at least a minute. Try to avoid tap water, raw food for sanitation, and you can use chlorine, bleach, or iodine to cleanse surfaces. And that's important in just thinking of when we have imported cases, which we'll talk about a little bit later in this presentation. We always think, okay, we're going to wash the fruit or whatever that's imported, and that's great. Please continue to do that. But just washing that off will not get rid of the hepatitis A if it's there. Okay, so it has to be actually heated, heating the food. So that's why there was outbreaks before with frozen fruit and frozen things, and people washed it off, but that wasn't necessarily enough to kill that. The other situation is routine immunization. This is now part of the vaccination schedule, and so that is a manner of prevention. And pre-exposure prophylaxis, which you're going to come across prior to travel to endemic areas. So those are the 3 situations that we talk about prevention. So for prevention, you have a couple of options. You have active immunization with the vaccine, as you're familiar with, and passive immunization with immune globulin. So active immunization is evidently preferred for prevention because it gives you lifelong immunity, right? And you're going to use your immune globulin in special situations when you can't use your vaccine, all right? These are the list of indications for hepatitis A routine immunization. So now all children at age 1 year, so anywhere from 12 to 23 months, they get vaccinated. They can catch up later, that's fine. Any travelers to countries that have high rates of hepatitis A, if you have an adopted child or family member and you're a caregiver and that adoptee is from a hepatitis A endemic area, men who have sex with men, uses of illicit substances, and I do want to emphasize this includes injection and non-injection. It's not just IV drug use, because remember, if you're sharing a joint, you have the manner of transmission. So keep that in mind. So people with chronic liver disease, including hepatitis B and C, they already have baseline liver issues. You want to avoid topping that off with hepatitis A. Anyone who's treated with clotting factor concentrate, because remember, those are pooled blood sources from multiple patients, so that's a risk factor. Of course, this is all screened for here in the US, and then people that are working in a research lab that deals with hepatitis A. The ACIP actually says any person wishing to be vaccinated should get immunized. That does not necessarily translate into coverage by insurance companies. So call your insurance first, but that's what the ACIP says. So that's routine immunization. When we look at the special situations where you can't use your vaccine, that's when that immune globulin is going to come in play for pre-exposure protection. So, and we will go into this in detail. I will explain why the cutoff of 40 years, but individuals more than 40 years, immunocompromised individuals that are unable to respond to the vaccine, if you already have chronic liver disease, chronic medical conditions, you're traveling and you aren't able to get the 2 full doses, if you're allergic to hepatitis A vaccine, or if you're less than 12 months of age and you're going to travel to an endemic area. And you can give, in this situation here, if they don't have enough time for the second shot, you can give the vaccine on one side and the immune globulin for pre-exposure protection at a different site. Okay? So what products are available for routine immunization and pre-exposure prophylaxis? So routine immunizations, there are 3 products available. Most of us are familiar with these. The 2 hepatitis A alone vaccines are inactivated. Both of these have adult and pediatric dosing, and you need 2 doses of vaccine. The schedule is at 0 to 6 to 18 months. Of course, you can go later than this and catch up. You don't have to start the series over. Twinrix is a combination product with Hep A and B. It's inactivated. There's only an adult dose, and this requires 3 shots. And this is partly because the dose of antigen in the Hep A is half of the other product. The immune globulin, there is 1 product licensed here in the States, and that's the Gammastan. This is not specific to hepatitis A. It has antibodies to measles, rubella, and varicella as well. The dosing varies. So we're talking about pre-exposure prophylaxis here. So if you're anticipating about a month of exposure, you're going to do 0.1 mLs per kilo. If you're anticipating 2 months of exposure, the dose is higher. If you're going to stay there for more than 2 months, you have to find somewhere over there that's going to give you another shot. So that's one of the limitations of this. But those are the products available. Now let's talk about efficacy. How good is this vaccine and how good is the immune globulin? So for healthy folks, 95% immunity after 1 dose and close to 100% immunity after 2 doses. The problem is that this immunity can vary in age groups. So the older you are, you might have a different immune response. So if you're older than 40 and specifically older than 60 going to older than 70, there's a lot of variation in the literature as far as the response, but the range can be anywhere from 60 to 69% with 1 dose. But most of these folks, when they get the second dose, they go to 100% immunity. And you get an antibody response in about 2 weeks after vaccine. In some cases, I've even read, even 10 days, you can already have a response to the vaccine. What about the immune globulin for pre-exposure? So there's a 90% decrease of incidence of Hep A infection if you use the immune globulin, if you have to use it. So this works. but it has some limitations. So that's how good the vaccine and the immune globulin are for prevention, right? So now that we've talked about prevention, let's talk a little bit about management, which I feel is where we're going to have a lot of questions with the current outbreak. So management, you're going to think of two situations, active infection or post-exposure prophylaxis. Those are the two main things. So for active infection, is there anything out there to treat hepatitis A for an active infection? So the short answer is no. They have looked at multiple different compounds and drugs. This virus is in the same family as enteroviruses, so they tried to look at some compounds that worked for enterovirus. They weren't very successful. They have looked at sofosbuvir, which is for Hep C. There was a recent article just earlier this year, basic science article. It does not seem to inhibit replication in non-hepatic cell lines, so it does inhibit Hep A, but a lot of further studies are needed. So right now, it's just supportive care. They have looked into it, haven't found anything particularly helpful for an acute active infection. What about post-exposure prophylaxis? So again, you have two options. You have the option of active immunization with the vaccine or passive immunization with the immune globulin. The products available are the same. You will notice I removed the combined Hep A, Hep B vaccine here just because the amount of antigen for Hep A is lower. So you do not want to use it in a post-exposure situation, okay? Because you want the highest amount of antigen there, and of course the immune globulin. Now again, in a post-exposure situation, if you have had at least one dose of Hep A vaccine given about a month prior to exposure, this may not be necessary. So let's talk a little bit about post-exposure prophylaxis. This is very interesting. So until 2006 in the US, the only thing that you used for post-exposure prophylaxis was the immune globulin. That makes sense, right? You had an exposure, you need those antibodies now, you're going to give immune globulin, right? That makes sense. They looked at that. Does it work? Yes, it works. It reduces your risk by, again, 90%. But there's some issues with immune globulin: cost, availability, side effects. And so people started thinking, okay, if the vaccine we know is good and you get good response within 10 to 14 days, can we use the vaccine in a post-exposure situation, right? So they looked at that in a few studies and they're like, yeah, this does work. It does decrease the incidence of infection. But there were no head-to-head studies between immune globulin and vaccine. So that was the problem for a long time until this landmark study that came out in 2007. So this was a head-to-head study looking at vaccine versus immune globulin for post-exposure prophylaxis in hepatitis A. So this was a study that was actually done in Kazakhstan, and this is an area with intermediate Hep A endemicity. They looked at about 1,900 patients that were close contacts of a confirmed hepatitis A case. The age group included, though, was only 2 to 40 years old in this study. They randomized the patients to each group. All of them received the intervention for each arm within 10 days of exposure. And they saw that the vaccine arm, there was 86% protection from getting the infection, and in the immune globulin, 90%. So it was proven to be non-inferior. Problem with that is that they only looked at those age groups. And you remember my gloom and doom slide, right? The older you get, the less predictable your response to the vaccine. So this study is what the change in the guidelines was based on. Before, only immune globulin for everybody. Problem with access, with costs, with side effects. Now, with this study, they're like, okay, we can use the vaccine for post-exposure prophylaxis also, but in select cases. So let's go into some more questions to look into what we do in post-exposure cases. Okay, so we're back to Mrs. X. Mrs. X has given us a lot of questions. So she's about to be discharged from the hospital, right? And she's asking if what do I do with our family members? You know, I live with my husband, my 1-year-old son, and I couldn't go to his 1-year appointment because I was in the hospital. So that's just to give you a clue that the kid didn't probably get his Hep A shot, right? So what are your recommendations? I made this kind of simple, but do you do post-exposure prophylaxis for all unvaccinated household members, or you wash them and do nothing until they develop symptoms? So any votes for A? Okay. Any votes for B? Not so much. Okay, good. So this is really post-exposure prophylaxis for all previously unvaccinated household members. So if you have a close personal contact of a confirmed infection, and by that we mean a household contact, sexual contact, or sharing illicit drugs, and again, this is both injection and non-injection, right? If no previous vaccine, they need post-exposure protection. Okay, so Mrs. X has a couple more questions. So you're giving her her discharge paper. She's ready to go. Then she gets a call from her husband. He's like, I wasn't feeling well. I started to go yellow. I went to my doctor yesterday. They diagnosed me with hepatitis A also. As she's getting this call, she's getting a text from her daycare center, right? They're like, is your son coming tomorrow and he's out of diapers? And that's significant. We will see why. How do you counsel this patient? So now you have 2 household contacts with the child, right? So the son needs post-exposure prophylaxis, assuming he didn't get the vaccine, right? Because they missed the appointment, but not any of his classmates. Her son, his classmates, and room teacher need post-exposure prophylaxis, but no one else. Or all previously unvaccinated daycare staff and attendees need post-exposure prophylaxis. So any votes for A? No. What about B? No. What about C? Okay. All right. So that is correct. So basically here, the significance of the daycare center having diapers or not is because your contact with stool is going to be greater, right? So that makes logical sense. So the recommendation is if you have a daycare center that does have kids with diapers, and you have 1 case or more in a kid or staff, or you have 2 household cases in the family, which is this case, then you are going to have to, if for all unvaccinated staff and attendees, you have to give post-exposure protection. What about for the daycare centers that don't have kids with diapers? So the case count is the same, but in that case, it'll be the classroom contacts only because you're limited exposure to stool, which is where you would transmit, okay? All right. So now you're finally trying to get her out the door, you counsel. And I want to add here that a lot of this is hypothetical. In a hospital situation, your infection prevention team is on board, your hospital epidemiologist is on board. You're going to have your answers, but this is for purposes of education. So you casually ask as she's going out the door, what does your husband do? So he's like, oh, he's a restaurant worker. What's the next best step now? So you ensure the health department is notified, which again, your infection prevention team in real life would have hopefully done that. And all the other food handlers need post-exposure prophylaxis if non-immune. No further action because the husband's not your patient, that's not your problem. Or all non-immune restaurant food handlers and patrons in contact with the husband over the last 2 weeks need post-exposure prophylaxis. Any votes for A? Okay. What about B? Nobody picked B, right? What about C? Some votes for C. Okay. So the answer for this one is A, okay? So let's talk about restaurant workers. So I know I have Dr. Kaloya here from the health department working a lot with this in this outbreak. So for food handlers, the risk here is twofold. One, mostly because of the contact with the food, but also food handlers may have additional risk factors that put them at risk for hepatitis A. But in this situation, the recommendation is that all the other food handlers at the same establishment should have post-exposure protection. How about tracking down all the patrons, right? Because that's your worry, right? You wait there and you got the notification, you saw in the news, the restaurant A has a worker with hepatitis A, and you're like, oh my gosh, I ate there last night. What do I do? So it's not really recommended as far as tracking down every single patron unless the food handler actually had explosive diarrhea. They were like seriously contaminating something, because you have to look at attack rate, right? So the likelihood of transmission from a casual contact like that will be lower. It's different in a household contact, okay? Again, that being said, this is all outside of the context of a big outbreak. We have to be flexible and take a case-by-case basis when we're making these judgment calls. At the end of the day, the guidelines are there to guide you, but ultimately you have to make a clinical judgment and figure that out. But that's the recommendation. Typically, you don't go after trying to track down every single patron. However, you will get those calls because people are going to be worried and they're going to be called, okay? So now that we know which groups need the post-exposure prophylaxis, how do we do the post-exposure prophylaxis? So if you have, it has to be done within 2 weeks, because that's when it works best. 2 weeks, within 2 weeks of exposure. The earlier, the better, okay? Even the 1 week mark is really good. So again, I'm going back to the gloom and doom slide and the discussion about why vaccine can now be used for post-exposure prophylaxis, right? So if you have somebody who's healthy, 12 months to 40 years of age, you prefer to give the vaccine, because we know that in this group, they will respond well to the vaccine, okay? If you have an old, and I take offense to this older definition here, over 41, but anyway, so if you're older, in that age group, remember that was not in the study. So we don't know how well this group does on just vaccine. So that is why the recommendation is to use immune globulin if available. If not, go ahead and use the vaccine, of course. And of course, special situations, immunocompromised, if you're younger than 1 year old, if you have chronic liver disease or you're allergic to the vaccine, then those are the special situations when you use immune globulin, okay? So hopefully that everyone's clear on why the age cutoffs and why we do this way. All right, now let's go to the interesting part of the talk, which is all about the outbreaks, okay? So these are the main risk groups for outbreaks for hepatitis A. So on this end here, you have community outbreaks, mostly endemic areas if you have a common contaminated food or water source. On this end here, I've put the international outbreaks, and that's importing food that's contaminated, okay? So we've had these here in the States. And then you have healthcare setting outbreaks and special groups, homeless and illicit drug use outbreaks, okay? So let's talk about the imported food outbreaks. So the recent ones that we've had in 2013, we had imported pomegranate seeds from Turkey. It was in an antioxidant blend, and it affected 10 US states with 162 cases, about half hospitalized and no deaths. We also had raw scallops from Philippines, and this was in Hawaii, in a chain of sushi restaurants. And here you had nearly 300 cases, 74 hospitalizations, and no deaths. And then you had frozen strawberries, also in 2016, and these were imported from Egypt. This went across 9 US states, and you had 143 cases, no deaths, about half hospitalized, a little less. I do want to say that all these products are now okay too, so you don't freak out that you had the smoothie from wherever. So that was the food outbreaks. Let's talk a little bit about healthcare workers, okay? That's the next group that we alluded to. So you start thinking about Mrs. X, and you're like, wow, this case is really complex, lots of questions here. So which healthcare workers need post-exposure prophylaxis? Everyone with direct contact, all healthcare workers with direct contact with Mrs. X that haven't had the vaccine. If Mrs. X is the only existing case of hepatitis, no post-exposure prophylaxis is really indicated. All previous unvaccinated healthcare workers on the floor during her stay, or all healthcare workers that were in the inpatient service at all during that stay. So this is a tricky question. But what do you guys think? A, all direct contact, who votes for A? B, if she's the only existing case, maybe it's not indicated. Some people shaking their heads. All previously unvaccinated healthcare workers on the floor. Some votes for that. Every healthcare worker that was inpatient. No, all right. Okay, good. So I had questions too about this question. This is why I brought it up. If you look at the guidelines, the answer is this. I kind of wanted to do A, and that's where I say that the guidelines are there to guide you. At the end of the day, you have to make a clinical judgment, because if you're a healthcare worker that was in contact with Mrs. X and is like, oh, she had a bout of explosive diarrhea, I was in there cleaning everything up, I don't know if I got my Hep A vaccine, would you really be like, there's only one case, it's okay, you're good, you know? So at the end of the day, yes, the guidelines are there, but you make your clinical judgment in conjunction with your friendly infection prevention team and your friendly hospital epidemiologist, right? Okay, so so let's look into what groups are associated with healthcare associated outbreaks. So one is usually infected kids, incontinent of stool, and folks did not adhere to the infection control measures. There was a breakdown in that. Foodborne, there was something contaminated either in the hospital cafeteria, or they were sharing food on the wards or in the break rooms. That's been described as a source of outbreaks in the healthcare setting. Invasive procedure, either cholecystectomy or EGD, and the equipment was contaminated from the previous patient, so that's happened. Patients of low socioeconomic status or with addiction, that is happening now. And also infusion of hepatitis A contaminated blood products, and that mostly in children who are getting infusions of some sort. So those are the big groups that have been described in the literature. And what about how well immune are our healthcare workers to hepatitis A? So when we looked at that, it's so varied, and it depends on where you're from. So there was this study here that kind of tried to compile worldwide studies on this issue. So in healthcare workers that were just grouped as healthcare workers, it varied from 32% immunity to Hep A to 78% in Brazil. Other compilations with physicians, 37 to 79%. Nurses and paramedics, very low percentage in Germany and higher in other countries. And cleaning staff was looked at too, because there are outbreaks reported in cleaning staff. So folks who are taking the sheets and the bedclothes to get clean. So that has been reported too. So it's variable. And here in the US, it's very hard to predict that. It really depends on where you're from. And if you got your Hep A vaccine, were you young enough to get it? So the attack rate reported for nursing staff is 15 to 27% in this compilation of studies, and for physicians about 3 to 4%. So that's like your attack rate. All right. So if you have, again, these are the guidelines, we already went through them, but use your clinical judgment. If it's a single case and the source of inspections outside the work or school setting, by guidelines, it's not indicated. If it's going around, now you have one case in healthcare workers and you're having more cases, then it's indicated. Okay, so now let's get to our multi-state outbreak. So what do you guys think is the most likely risk factor that has been identified in this recent multi-state outbreak? Is it a common contaminated water source, illicit substance use and or homelessness, or common contaminated food source? Who votes for A? See some votes for A. What about B? Lots of votes for B. And C? Couple votes for C. Okay. So this current outbreak, that is the main identified risk factor. So let's talk about these state outbreaks. So right now, these are the states that have it. Michigan started back in August of 2016. There are 821 cases. You can see 80% hospitalized and about 3% deaths. Utah was the next one. You can see the amount of cases, amount hospitalized and deaths. California, you can see the amount of cases and deaths. Kentucky, this is where we were last. And this is sort of the rate of hospitalizations, and this is the amount of deaths. Indiana just kind of started out at the same time, but less cases here. The only state where this seems to be letting up is California. So far, all the other states are still having a lot of cases. So let's look at our distribution here. So as you can see, this is us, and we have the most number. And actually, this number has been updated to 327 now, as of a couple days ago. But that's where we're at. And let's look at the age distribution. So you can see these are the age groups that are mostly affected, and these are all from the health department report that's online. These are the risk factors for Kentucky, and as most of you correctly pointed out, the illicit drug use, again, is the majority, and the combination, if you do the combined here, that's the majority. Some MSM, some no risk factors, and unknown risk is where you weren't able to contact the health department, or prevention wasn't able to contact the patients to figure out what the risk factor was. So here in Jefferson County, that's our breakdown roughly. So you can see illicit drug use is really the predominant one. And this was a very interesting slide, also from the health department website. So if you look at the little green dots, those are the syringe exchange programs. The blue lines are the major interstates, and the gray are the counties with cases. So you can see the major interstates, the exchange program, and right there's all the clusters of cases. So that's very interesting to look at. This is another map that Dr. Polloy actually gave me. So these are all the cases, and these actually mirror the arrest maps for drug-related offenses. So that's very telling as far as where this is coming. Okay, this is kind of the map of the outbreak. The outbreak was officially declared, I believe, in November. We had some cases before, but you see March and you see April, we're kind of topping that. So it's ongoing. And so what are the community prevention efforts, right? So basically right now, the focus is on vaccines, right? So this takes a lot of effort from the public health department to coordinate all these community partnerships, right? Because specific partners are going to focus on specific groups. Right now, the health department is focusing on some of those folks who have limited resources as far as giving them vaccines. So they are pairing up with all these community partners. So at the Department of Corrections, more than 4,200 vaccines given. The UofL outpatient pharmacies are here, the ACB, focusing on healthcare workers, EMS, fire departments, if you're a provider for homeless. So they've given this many vaccines, 1,900. Our vaccine clinic, so Dr. Ruth Carrico is heading that effort, is focusing on food service workers, more than 5,000 vaccines given at this point in time. And if you count all the sites, more than close to 27, getting close to 30,000 vaccines given at this point in time. As far as focusing on our clinic, so that's our little van, the ID van. We also do outreach besides the clinic. So these are some of the places we've gone to. So local restaurants, downtown hotels, so 4th Street Live, retail complexes. We've done a lot of work just going to them. You can't come to us, we'll go to you. So definitely something that we've been doing in conjunction with the health department. This is a link which would be very important for you. And there's a couple of handouts I've printed on the way out. And this is where can I get my hepatitis A vaccine? Because you're going to be getting calls from folks. And this link really details if you have insurance, per age, if you don't have insurance. But the takeaway point is there's no shortage of vaccine, and have your patient call their insurance, because sometimes the insurance will approve a vaccine being given in an office setting, but not in a pharmacy setting. So you have to just make that call, okay? And this is the summary. So this is a preventable disease, high vaccine efficacy. There's no specific antiviral for treatment. You need to understand the indications for post-exposure prophylaxis and work with your team of infection prevention, health department, and hospital epidemiology. Controlling an outbreak calls for a very, very coordinated effort between public health authorities and all the community partners. and there is no current shortage of vaccine. So that's all I had for you today, and I'll open it to questions. Thank you.
Thank you. That was great. That was great. It was informative and entertaining both. Yes.
Mm-hmm. Mm-hmm. Right. So the questions were, can patients on biologics get hepatitis A vaccine safely, and what is the efficacy in that population? So the first question you already answered, and yes, it is safe because it's inactivated, as we would imagine. As far as the efficacy in that population, there's not a whole lot of data. I do know for HIV positive patients, another immunocompromised group, their rate of response tends to be lower, between, again, varied 60 to 85% in some cases. So the answer is we don't know, but it doesn't hurt to get it. So, yes. Mm-hmm. So the question is, people have had the vaccine in the remote past, and by that, do you mean the full? They got the full series, the 2-dose series, or just yes? So the recommendation is that if you've been vaccinated in the past with a 2-dose series, you are considered to have lifelong protection. So that is the recommendation. Yes. So and correct me if I'm wrong, Lori, this is pooled from donors. So yes. Which is why they made the push to look into vaccine for post-exposure, because there was that risk. That is correct. And as far as to your first question, I don't have an answer for that. Sorry. Yeah. So if I look at the experience from California, which is the only state where it's starting to slow down, they did do massive immunization. Like they gave more than 123,000 vaccines. So I think the problem is because our vaccine recommendations changed later and we were not considered intermediate or high endemicity, our immunity out in the community is not great. So if you have an outbreak risk, and as healthcare workers, we're going to see this more, if you don't know for healthcare workers, as far as the larger population, you don't know who you're going to come in contact with or who. So I think from ACIP standpoint, it's recommended to get immunized for Hep A. But you're right. If there is some of the hysteria that, oh my gosh, I ate it wherever, or I'm going to get it from wherever. Yes, they might not be the risk group now, and that's true, but you don't know how far this is going to go. That's also a wide net of variability. Lori, yeah. 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 Oh, geez. Sorry, she's. The the problem with so your question was, why are we focusing on food service workers? Is that your question? Well, we're not really only focusing on food service workers. That's one of the groups that the community partners are working with. The health department is certainly focusing on the main groups. The problem is access to those groups. If the homeless and illicit drug users, they might be a little harder to get a hold of, so. But if the slides were portrayed that way or interpreted that way, that is not the case. That is one of the community partnership is food workers. Then there's all these other groups that are being targeted, including the main group. Yes.
A question about
So there is a high rate of co-infection with Hep B and C. Unfortunately, I don't have the exact numbers in our outbreak. That is correct. And when you look at the death rate, it is what would be expected with hepatitis A in general, I would say. But definitely the co-infected, we know that they're going to do worse. So, but that is definitely a factor in it. DC.
I was going to ask, so go to grocery store. Fruits and vegetables are from all over the world now. And I don't usually heat up my peaches to 185 degrees Fahrenheit. so I mean, how are we assured that the food sources?
We're just not. Yeah, we're just not. So for us, really, the best solution is make sure you're up to date with your vaccine. Then you can eat whatever You don't need to heat up your peaches, but getting sick, yeah. Mm. Thank you. Thank you.